All right. Well, it's my pleasure today to introduce Dr. David Elkin, who is the Executive Director for the Center for Advancement of Youth at the University of Mississippi Medical Center. Dr. Elkin and I have known each other for quite some time and go way back. And so it's a pleasure to have him here today to talk a little bit about the program. So first off, do you want to tell folks just a bit about your history, your training background, and how you got to Mississippi?
Sure. So I guess technically my family's from here. Went through fourth grade here, then moved to Memphis. I did undergraduate in Nashville, and then PhD work at University of Memphis, and then internship and fellowship at the University of Oklahoma Health Science Center, and then moved back to Mississippi for my first job after my fellowship in OU. My first job in '99.
And on the way, you went to seminary.
That's right. Sorry, I didn't mean to leave that out. So in between college and graduate school, I did go to seminary and get a master's of divinity. But I have a very long-suffering wife. It's a woman who puts up with a lot of education and lean years.
There you go. There you go. Well, tell us a little bit about the center and its history, how it evolved over time, and the mission of the center.
So, a medical school. Not all of them, but historically a medical school has been a very it's been organized around departments. It's the last bastion of feudalism. Each little department has its own kingdom, its fiefdom, and never the two shall cross in a sense. And I think that's changing actually nationally. People are starting to tear down silos and operate across departments. And so this center is sort of following in that tradition, that new tradition now is springing up. The idea was, there are people in pediatrics, and there are people in psychiatry, and even other departments that are kind of doing similar things, working with kids with developmental, behavioral, emotional disorders. And so why don't we just all pull together in one center and sort of, again, work together, pool our resources, streamline the care. And so I have to give credit to the chairs of pediatrics and psychiatry. The chair of pediatrics is a woman named Mary Taylor. And she's a cardiologist by training. And the chair of psychiatry is a guy named Scott Rogers. He's a child psychiatrist. And they both sort of trusted us with this. they believed, I guess, which is kind of amazing. And they committed resources to this. And so we pulled people from psychiatry, from pediatrics, and now we have our own OT and PT suites. We have speech therapy. We have child psychiatry, child psychology, developmental behavioral pediatrics, a lot of nurse practitioners, a lot of licensed professional counselors, LCSWs, nursing staff, support staff. And it's all in one outpatient location, and 20,000 square foot location that's got really good parking. So it's kind of amazing that a medical school sort of bought into this idea of shared space, pooled resources, and everybody working together for a common cause.
So truly an interdisciplinary effort across departments, crossing those boundaries, working together, which is a little bit difficult to accomplish, to say the least.
It is, because we still have our academic appointments. So my primary appointment is still in psychiatry. And I have an ancillary appointment in pediatrics. Other colleagues have their primary appointments in pediatrics. So there's sort of this like amorphous, in a sense, reporting system. But I kind of dig on that. I kind of like having sort of a flat, I guess, administrative schedule kind of thing, or org chart even. We try to be Google-ish here so that everybody's on the same page. I'm degree agnostic. I don't care what letters you have after your name. If you have a good idea or if you're the right person for a job, then you've got it. And it took people a little while to get used to that because they're used to having a reporting schedule. Like this is my direct report. I report to my chairman here or the division chief here. And technically they still do, but really they don't. So they're over here and they kind of report to this leadership team. But the leadership team is made up of members of we have 5 committees here that sort of run the show. And we require all employees to be on one of the committees, even frontline staff, even schedulers. I want schedulers to be involved in the clinical operations committee because they know what's going on. So it took several years actually to sort of get people used to the fact that it's okay. You can operate in a system that's very flat and not hierarchical. And the result has been kind of fun because you see really great ideas come from people that you really wouldn't expect it. One of our LMSWs just got a pretty sizable grant to run an anxiety camp for kids, and so I love it when people like that can do academic scholarship-based kind of things.
Absolutely. So it really fosters that egalitarian aspect, really fosters creativity, and the barriers are kind of broken down, the traditional barriers.
I kind of see my job at this stage is to sort of clear paths in front of people and sort of get out of their way. I think that's sort of my leadership style anyway. I'm not sort of a heavy-handed, top-down, do as I say kind of person. If somebody has an idea and it gets vetted by the group, then my job is to break down barriers so they can accomplish it. At this stage in my career, I kind of like doing that rather than having to come up with the ideas. Let people come up with the ideas and then help them getting them implemented.
And realize those opportunities. Sure. So tell us a little bit about the patient populations you serve, and what kinds of services you're offering that are kind of unique and innovative.
So we have we serve the whole state. We're the only children's hospital in the state, so we don't really have much competition. We serve probably about 7,500 to 8,000 unique medical record numbers last year. We had about 47,000 encounters. We get between 35 and 40 new referrals a day around the state. 2/3 of our patients are Medicaid because we're the University of Mississippi Medical Center. And we have a very healthy telehealth program. So probably about a quarter of all of our visits are done via telehealth. Mississippi has a very robust telehealth infrastructure. Mississippi and South Carolina are the two centers of excellence currently for telehealth in the nation, recognized by HRSA. And so we like to joke and say the first two states that seceded from the union are now trying to actually come back in and do something right this time. And so we're able to do telehealth really in every county in Mississippi, all 82 counties. We serve kids really from like almost birth, several months old, all the way up to 18.
Okay. And so the array of presenting difficulties can include what?
Anything developmental, emotional, behavioral you can think of. Our big players, obviously, from looking at our data, our big diagnoses are ADHD, autism, anxiety, depression, but we really see just about anything. We take referrals from primary care providers only. We don't take referrals from parents or from schools or anything like that because we're trying to keep the medical home intact. That's strategic because I believe that's the right way to go. It's also strategic in the sense that over the next few years, what we're trying to do is push care upstream to those primary care providers and do more locally in those individual clinics. We're not going to be able to put a psychologist or a psychiatrist in every clinic across the state of Mississippi. But if we can sort of provide a structural network and consultation with them, then we want to keep it that way. So we only take referrals from PCPs around the state.
Okay. And I would think that that's relatively novel in that you don't really take referrals from parents. You're working directly with the PCPs in a truly kind of integrated behavioral health manner.
My fear is if I've thought of something, there's no way it can be novel. There's absolutely no way. So I'm sure other people are doing it. But again, that was the strong opinion of my partner, Susan Buttress. She's a developmental behavioral pediatrician here. And she, a lot of the folks here in the state have been are trained through pediatrics here. And so she wanted to not come across as patient stealing, stepping on toes, but rather being collaborative with the primary care providers across the state. And I think it's paid off in dividends in terms of level of trust. So they know that we're on their side and we're supporting them. And so we're able, therefore, to sort of push some things upstream in terms of care and care models locally. And it's sort of been a nice symbiotic relationship.
Sure. I'm just kind of curious, David, what does that communication look like once the parents have entered your system? There's an evaluation, there's a set of recommendations. How do you guys facilitate that communication with the PCPs?
So the electronic health record system we use here is Epic. And Epic has a lot of nice features for that. So they get an immediate um, letter, your child was seen this day in K Center, here's the disposition, we're going to bring him back for therapy, we're starting on medication, that kind of thing. We also ask the PCPs if they want to be involved in the medicine dispensing, prescription writing, that kind of stuff. Some do, some don't. If they don't, we'll take care of it here. But we communicate back and forth through the electronic health records. Some of the older practices don't have access to Epic. That's fine. They can sign up for Epic Care. They can sort of come in on the side, if you will. But for those folks, we send old-fashioned emails.
Okay. And so the feedback you received thus far is that kind of collaboration has really worked out well.
I think so. It allows us to sort of, like I said, try some new things, at least new for us. For instance, we have a program that's funded by HRSA called the CHAMP program. The CHAMP stands for Child Access to Mental Health and Psychiatry. And it's based on the model that came out of Dr. Strauss's program in Massachusetts at Boston Children's. It's also in New York and Oregon and other places where you're not going to get enough child psychiatrists in rural parts of the state, even in Jackson. And so what they do is they have a child psychiatrist, my colleague, Philip Meredith, who and his team, they're on call in a sense during the day. And so if you're a PCP in small town Mississippi, pediatrician, let's say, you may feel comfortable writing a prescription for ADHD medication, but you may not for anxiety or depression. You may want to refer that to a child psychiatrist, but it takes forever to get in to see them. But if that pediatrician knows that he or she can call or telehealth in and talk to a board certified child psychiatrist, and this psychiatrist says, oh, for that I tried 20 milligrams Paxil, and they check in weekly, and the care stays local, child doesn't have to travel, mom doesn't take off for work, and that pediatrician who knows that family better than we ever will, the care stays right there with him or her. And that's going quite well. Again, we didn't think of that. That was modeled, started in Massachusetts, but it's really worked well here in rural parts of the state.
Sure. And clearly it breaks down those typical barriers to care, including transportation, distance to the medical center, access to multiple providers with specialization in child psychiatry and psychology. So
yeah, and I think it positions us the way I want us to be positioned, which is we're partners, with these folks across the state. We're not here to compete. We're not here to take patients. We want to partner with y'all. I think Arkansas does a good job of that as well. I mean, Arkansas does a great job of reaching out and having sort of these networks of pediatricians and primary care providers across the state. And we're trying to do the same thing that they are.
Okay. So out of curiosity, what have been some of the biggest obstacles for you guys to roll this out? Biggest barriers for you creating this program?
When I was younger, I used to ask my dad a lot of why questions, why this, why that. And my dad's somewhat smart pants response, but trenchant and true response was, what's the answer to most questions, son? And the answer to most questions is money. Why did that person do this? What's the answer to most questions, son? So the answer to your question is money. It's been the biggest barrier because kids' behavioral health doesn't get reimbursed at a good rate. And so traditionally, a center like this, or pediatric behavioral health in general, at a medical school is kind of like the English department at a university. You've got to have it, but you're not going to make any money with it. And so convincing administration and those kind of folks that this thing that in the past had been a money loser, we've been able to streamline all the services together. We've been able to actually break even and make a little bit of money. But even then, if you are the dean of a medical school and you've got two cost centers, one that makes $1 million a month and one that barely breaks even, which one do you invest in? The one that makes $1 million a month. So cardiology, ICU, that kind of stuff. Orthopedics, those are big money makers, and we're not. And so, you can talk all you want to about, but we're helping kids and kids of the future, and it's about the children. And I realized a long time ago that was just falling on deaf ears. I mean, people will pay lip service at it. So yeah, we want to help the kids, but it's a business. And so I guess one of the things I want to pass on to folks, to your trainees, is to start thinking about the business model, because you have to be able to talk that talk when you're talking to division chiefs, chairs, academic deans, that kind of stuff. So we were able to demonstrate that we were, just right there with our nose barely above water. And then once you start doing that, you can reach out for philanthropy. And philanthropy has been very important to us. It's just talking to people about investing and all this. It's taken several years, but once you get one good sized donation, then people want to jump on board. And that's sort of been my job as well, is to be out there sort of beating the bushes and advocating financially for what we do.
So you've been able to also look at garnering resources through philanthropy, fundraising, et cetera. I mean, it's
Yeah.
not lost on you and I that there's a hospital in Ohio that's called Nationwide. So how have you managed to go forward as a pediatric psychologist and learn how to fundraise? What's that been like for you?
It's been a learning experience, like anything else, I guess. We're not taught to ask for things, generally. We're not taught to advocate for things. We're taught to listen and to give advice to patients, but not to get out there and say what we do matters. And here's why, and actually to have a pro forma, if you will, or a business model on why it does matter. I was fortunate in that the medical school has a relationship with a local liberal arts college here in Jackson called Millsaps College. And Millsaps has an MBA program. And so what the medical school does is send people, I was in a class of like 10 medical school faculty that went and did a semester long. It was called Business Advantage for Professionals. So it wasn't an MBA, but it was a very intense semester of business kind of practices. And that really helped me learn how to organize things financially and to keep track of things financially. So again, one of the bits and pieces I try to tell our trainees as well is, at every opportunity, get some kind of business experience. It goes against the grain for us, for me and you, and for academic psychology, because it feels like business is filthy lucre, and it feels like that's something that the hoi polloi do, kind of thing. We're pure, we're academics, and it's easy to think that until you realize academics is a business. It's part of it, and you know that as well as I do. I mean, you've had to, as a chair, you've had to sort of learn how to talk that talk.
Exactly. I've shared many times that being a department chair essentially means you are running a small business of 60 to 120 employees, depending upon how you count them. And we're not taught how to do that necessarily in graduate school. So
That's right.
So kind of veering off in a different direction, integration of technology. You've talked about the issue of telehealth and its importance. What data analytics are you guys involved in, kind of crunching numbers and using those numbers to kind of support your efforts to fundraise and lobby for more resources?
Yeah, so we've been very fortunate in that I was able to get some money from a local foundation to literally pay for the time of a person here in the data analytics section of the medical school. I realized that too. You can go to the medical school data analytics folks and say, here's a question, can you answer? And they'll say, sure. And 6 months go by, nothing's answered. But if you come and say, I'll pay for half of this person's time, then you get quick answers. So we did that. And they've set up a very nice data set that's updated daily in Epic. And so we can look at no-show rates. We can look at how no-show rates vary by provider, by diagnosis, by zip code in the state. So we can really start slicing the data that way. One of our internal QI projects right now, because of that, is to get our no-show rate down. I've set it aspirationally at 15%. Right now, we're running at about 22, 23% for 2020. I want to get it down to 15%. And to do that, you have to start looking at the data of no-show. Is it related to how far away they live? Is it related to SES? Is it related to diagnosis or access or whatever? And so we make use of the data on a daily basis. And we're also trying to automate a lot of the things that are more redundant and yet personnel heavy, like the schedule and triage and screening process. So right now what happens is a pediatrician will send a referral in electronically, and literally one of our schedulers will look at it and see what the boxes they checked and say, okay, this child needs to go to a dyad, which is a pediatrician and a psychologist for an initial evaluation, or it needs to go to med management with a nurse practitioner, or behavior therapy with a psychologist or LPC. I think we can automate that. And so we worked with a local software company here to develop a program that will do that, and we'll learn based on corrections we give it. You know, it has the potential, which is very interesting to me, to learn that that pediatrician from Greenwood, Mississippi, who always refers a kid for ADHD, it usually turns out that kid has anxiety. You know, so it starts learning based on providers too, kind of what their referral pattern looks like. And so it will drop a kid into a treatment pathway here at the center that a human can then look at and see, you know, is that the right pathway or not? But it saves time. So we're trying to sort of push the edge a little bit. I think other places are doing this too. You know, Cleveland Clinic's done that kind of thing for a while. But with pediatric behavioral health, I think we're trying to automate as much as we can.
Absolutely. Interesting use of a community partner to kind of do machine learning, you know, and find those solutions. Very interesting.
We work with, so the Center for Telehealth here works with a local cell phone service. C-Spire is the 6th largest cell phone carrier in the nation, and they're based in Jackson, Mississippi. They know they're never going to be AT&T and Verizon. They know that. So they're going horizontal. They're getting into healthcare and direct patient care, and we're working with them on that very thing. So they're laying lots of fiber optic cable across the state, and also the satellite stuff. They're going to be involved in that. And so, you know, thinking of how we can take that concept of integrating medical care and psychological care. You know, it's all health, right? It's not mental health versus physical health, it's health. So how do you integrate those things in a rural state like Mississippi, a rural poor state like Mississippi? And you have to use technology. You can't just hire your way out of this. You can't hire 10 more child psychiatrists and 20 more child psychologists, and then you can service the state. You've got to tech your way out of this, I think. And then that's been very interesting to sort of watch how that has developed here.
You got to tech your way out of it. I like that. So David, if I was to say we need to implement something like this in the state of Oklahoma, give me the 5 pointers on how we would extract the model, mold it and shape it, and make things happen in a state that you know pretty well.
I'd work on working with the medical school on interdepartmental cooperation. You know, so getting departments to share resources and share personnel like this would be the first step. Partnering with local universities and colleges to do workforce development, honestly. So one of the things we're doing is we're delivering telehealth into schools in rural Mississippi. We're targeting those schools that are near HBCUs. So Alcorn State University is an HBCU, and they have an LPC program. Those LPC students need hours. So we're going to have them in the schools while we do telehealth. They get their hours. We get the use of them moving the kids around the school, and it's a nice partnership. And if nothing else, then we can hire some of those folks down the road. We've got our fingerprints all over them. And if we don't hire them, then they're familiar with things like PracticeWise, which guides our therapy, and they're familiar with evidence-based care. So even if they don't come to work here with us, they're across Mississippi, then they've been well trained. So I'd partner with local universities and colleges. I would get with philanthropists, I mean, people who can give money, because this is going to take financial backing to get it off the ground. And I would develop a system that is very collaborative and, again, degree agnostic, focusing on everybody. Everybody has the ability to pull the stop button and stop the assembly line. Everybody has an opportunity to say, hang on, I see an opportunity for improvement here. Why don't we do this? You know, um, is that 4? I'll stop at 4.
That's great. That
You
is
challenged me
great.
with 5, but I couldn't come up with 5. Sorry.
Clearly, one of the things you want to do is to identify those partners who kind of share that same vision, that desire to blur those lines in the interest of moving forward with kids' health. You know, you mentioned before little tips and pointers for graduate students in training, including dabbling a little bit, you know, in the business model. You know, maybe snagging an MBA on the way, but at least you know, immersing yourself in what a pro forma is, et cetera. So any other suggestions that you would make for graduate students in training?
Um, you know, I've said this before, and I think you agree. I think you probably taught me this, honestly, as a friend and a colleague. You know, I would think of pediatric psychology as psychology. I think historically, pediatric psychology has been consigned to, or consigned is a bad word, has been limited to um, kids with health conditions like cancer, sickle cell, diabetes, that kind of stuff. I think that as we start blurring the lines more and more, it's basically pediatric psychology is child psychology is pediatric psychology. And so I guess getting people comfortable with ped psych is ADHD, ped psych is depression, anxiety, because these kids have health concerns as well. The child may have autism, but the child may also have, you know, obesity. If you're in Mississippi, you know, one of the most obese states in the country. And so I think that sort of thinking of pediatric psychology as just psychology, really, and not limiting yourself to one specific area, I think is a helpful thing.
Great, great. So the next steps for the center as you see them, what do you envision?
More use of technology across the state. We're working with a company out of the UK called Silver Cloud, and they're developing. They have a handheld-based um, delivery system for behavior therapy for adults. They're working with us for adolescents and young kids. There are other companies out there that do it as well, but we're interested in them because they have a contract with Kaiser Permanente in California and the National Health Service in the UK. And so, you know, thinking about ways that we can have treatment extenders. So if I see a kid, you know, this afternoon, between the time that I see her and the next time she comes back in, what if she's getting pings on her phone and that's being tracked in our electronic health record system, but how she's doing and is she implementing the things we talked about, that kind of stuff. And I really would like, before I retire or die, I really would like to get into direct patient care, honestly. Just kind of like Intermountain Healthcare is doing out in Salt Lake City. Just having a system where we work directly with patients and don't go through third-party payers. That's pie in the sky. That'll probably be something that my kids or grandkids have to solve. But for right now, it's aspirational.
Sure. Well, it's interesting to hear you talk about Silver Cloud and practice-wise. I mean, you're obviously looking for partners and models of contemporary evidence-based care using innovation and technology and merging those things, as opposed to attempting to do it all from the ground up in Jackson,
Exactly.
Mississippi.
Yeah, we can't do it all ourselves. And I think that it's kind of a weird thing to say, but you know, the human being is becoming digitized, right? So, you know, you get an MRI of your head, and it's really binary code. Why can't behavior be the same way? Why can't we somehow track what people are doing behaviorally and I guess help people behaviorally in those ways?
Exactly. Okay. Anything else you would like to share? Any other bits of wisdom?
Um, be bold, be unafraid to your students. You know, step out there and try things. You may fail. Yeah, it's so much better. I would much rather have somebody that I have to rein in than somebody I have to fire up. as a colleague. I'd rather have somebody who has an idea and it fails spectacularly than someone who has no ideas. So it's fun to see people sort of start playing with ideas. The idea to go in to do telehealth in rural schools here and partner with HBCUs was proposed by one of our LPCs. He just said, "What if we do this?" I said, "That's a great idea." So again, encourage your students to have bold ideas and to dream big on how to help people.
It pays to be a little bit fearless, doesn't it? So that's
Here we are.
one of the things we look for in trainees is that fearlessness, because
That's right.
many things in life worth having, as they say, are just on the other side of fear. So, well, thanks so much. Really appreciate your thoughts about the center and the great things that you guys have done. So it's much appreciated.
I love talking with you. Thanks for having me on.